So now I have a question for both of you. The one that's challenging for me, yes, those two studies are exciting. However, they're only focusing for the patient with residual disease at the time of surgery. Nowadays, we know with the therapy we have, we can achieve past CR in about 60% of the patients. And with the Destiny Breast 11, we don't know the results, but from the press release, they're aiming somewhere upward of 80% past CR. So really, residual disease is going to be between 20 to 40% the way we see it. But you guys did discuss earlier on that even the past CR patients are at the same risk of CNS recurrence compared to our residual disease patient. Yet those are excluded from those two studies, from the Destiny Breast 05 and the Compass HER2 RD. So we don't know if tucatinib is going to help them or T-DXd is going to help them in reducing their CNS recurrences. So I'm going to start with you first, Dr. Birhiray, and then Dr. Kang. Where do you think neratinib is going to play? Is it going to still have a role when those two studies are eventually resulted and are available to us?
I believe so. Of course, we're speculating. And again, the reason why I state that so emphatically is that you talked about the fact that those patients who do not achieve a pass CR will not be studied, so we won't have data. The only data we would have will be with neratinib, so that's already there. And unless you show data that says compared to neratinib, these combinations are superior, in the absence of that kind of data, then neratinib remains an option for those patients. So I don't think that the studies are being designed to really answer the clinically meaningful question to me, and maybe they will never be, simply because the ball keeps moving. Where do specific drugs fit? But I still go back to the fact that we have data that shows that neratinib, given in the extended adjuvant setting, can reduce the risk of recurrence, both outside the brain, but most importantly, the brain, because the other drugs just don't get there.
Perfect. Dr. Kang, do you have anything to add to that?
There's sort of additive toxicities with some of these regimens, risk of pneumonitis with trastuzumab deruxtecan, as well as, a combination of tucatinib and T-DM1 at the same time. I would anticipate running into at least LFT abnormalities quite a bit, nausea with the combination. So, if you have someone who maybe doesn't complete the 14 cycles of trastuzumab deruxtecan or tucatinib, you have this opportunity to use a drug by itself, so in its sort of best tolerated state, after for high-risk residual disease individuals, and then completely for the PathCR population. We don't have data on using anything else outside of trastuzumab and plus minus pertuzumab. So neratinib still sort of is the only agent we have in that setting.
I mean, you both nailed it, and I like about the side effect issue. I'm glad that's the only thing I have to deal with. Neratinib is diarrhea, to be honest. It's drug related. You stop it, the diarrhea is gone. ILD can be permanent, right? And I'm really worried about that. The combination of T-DM1 to tucatinib, although we don't know the results from the early setting, but from the metastatic setting, the LFT is definitely concerning, and the pseudocirrhosis that happened, the caking of the liver that happened when you give this combination that was already reported in the metastatic setting in the HER2 CLIMB-02 with the combination of T-DM1 to tucatinib is concerning for me. I mean, yes, we want to cure our patient in the early setting, but we don't want them to be stuck with lifelong diseases that they have to deal with. So again, for me, diarrhea, I'll take it every day of the week compared to lifelong issues that can stick with the patient.